Welcome to another episode of Veterans Health Today. Here is where you learn about the services, programs, and benefits offered at the Dayton VA Medical Center. I'm your host, Public Affairs Officer Rhonda Moore. Dayton is home to not only one of the first VA campuses, but also a state-of-the-art medical facility offering top-quality care to those veterans in need. Our heritage dates to President Abraham Lincoln, who signed legislation creating our campus and what's now the modern VA. Our mission is to fulfill his promise to care for those who served in our nation's military and for their families, caregivers, and survivors through the employment of modern medical services, many of which are geared to the special needs of our veterans. Don't wait, reach out. That's the theme for a national campaign encouraging veterans to seek help if they're struggling with life's challenges and to do so before it turns into a crisis. September is Suicide Prevention Awareness Month, and here to talk about the help that Dayton VA offers is Jay Wainscott, the program manager. And thanks for being here, Jay.
Thanks, Rhonda, for having me. I appreciate it.
Tell me, what does the program manager do?
So I oversee the suicide prevention team. We have a large team at the Dayton VA Medical Center that's comprised of all senior clinicians, all right, and into two different roles. So we have a suicide prevention coordinator role, and we also have a community engagement partnerships coordinator role.
So let's talk some harsh reality and harsh numbers. How many veterans commit suicide each day?
The current data that we have indicates there's about 17 veterans a day on average that are committing suicide across the country. But you know, when we think about a veteran death, or anyone's death for that matter, you know, one death is too many because they're all preventable.
Mm-hmm. Now, is there a profile of a person who's most likely to commit suicide?
Yeah, no, I wouldn't say there's a profile of someone that's going to commit suicide, and I think that's one of the most challenging things when we think about suicide and suicide prevention as a whole. What we look at from a clinical standpoint is we look at risk factors versus protective factors. You know, and risk factors are all the different things that can take place in a person's life, whether it be the stress of finances, job loss, relationship issues, grief, trauma is the big one for veterans. You know, there's just not one particular indicator that's going to identify or profile a person that is likely to commit suicide. If you or I were to walk in tomorrow, you know, and we're told we're going to lose our job, that's an automatic risk factor or stress factor in our job. Now, what makes the difference between someone that becomes suicidal and someone that doesn't when they experience a risk factor is the protective factors that they have in place. You know, when we think about protective factors, it's a support person, it's a coping skill, it's a cognitive skill. There's just a multitude of different things. You know, how do we spend our time? You know, what recreational activities do we have? What do our roles look like in life? Those are all protective factors that we have. You know, are we able to eat, provide for our housing? You know,
I guess that's what I'm asking is money an issue a lot of times, or say divorce?
What's the cause thing?
And you can't really say.
Can't really say, you know, and we don't know, depending upon whether a person leaves a note or doesn't leave a note when they commit suicide. What I have seen when I'm doing reports on suicide loss, when I get those, when I get informed of those, you know, the families that I reach out to and have those conversations with, oftentimes are just as much of a loss as well, because they feel like the person did have those protective factors.
And talk about veterans being at higher risk of suicide compared to the general population.
Yeah, it's about 1.8% higher right at this point in time. And when we think about that, and that's currently, we were just discussing this a little bit ago with some of the team members, and for the 18 to 35 population, it's 2.8% higher than in general population.
And why is that?
That's a great question, but if you look about it, you know, when a person gets out of the military, right? So when they're getting out at, whether they've done a 4-year enlistment, or a 6-year or an 8-year or 10 years, whatever that looks like for that particular individual. They go from, the military is all about structure, all about your role, your purpose, right? When they get out, they oftentimes don't have that. They can feel at a loss. They can have a sense of hopelessness. Also depends on how they, if we think back in the day, how they were received in the community. It's a little bit different these days than it used to be. And then also the experiences that they had while they were in the military. It's a tough job that all of our service members do, and some of the things that they have to go through and some of the trauma that they experience, they carry with them. So when they come out, we hope that they're going to reach out and get support from us. Whether they do or not, trauma in and of itself inherently, some of the symptoms of that are isolation. The person doesn't want to reach out. They don't want to seek help.
So does a veteran have to be enrolled at the Dayton VA in order to get help?
That's a great question. No. If a veteran is experiencing an acute crisis at that point in time, they do not have to reach out and begin eligibility at the Dayton VA. There's a Compact Act that began back in January of this year that offers to cover all costs as it relates to that acute suicidal crisis at that point in time. So it'll provide transportation, it'll provide covering any cost incurred at whatever medical facility they go to, and then continued follow-up for 30 days of residential care or 90 days of outpatient care. So they could conceivably get 120 days of care due to that one incident if they go for 30 days of residential as it relates to that particular incident, and then an additional 90 days of outpatient. But the whole purpose is that in that acute crisis at that point in time, the biggest thing that we want to do is be able to provide support and stabilize.
So where can they get more information about the Compact Act, since you just mentioned that, if someone is interested in finding out about that?
They can get online and just Google Compact Act. It'll come right up and they can find out all the information. But it is just that simple. The hospitals all know about this too. When you meet with our Community Engagement Partnerships Coordinator, it'll tell you about the role that they're doing and providing that information out to all the providers in the area, all the external stakeholders.
Now earlier you said suicide is preventable.
Sure.
Explain that.
So at the Dayton VA, our suicide prevention team is responsible for providing a SAVE training. SAVE's an acronym like everything else in our VA, and it stands for, the S stands for signs. We want to look for signs that the person is experiencing stress in their life, those risk factors that we were talking about earlier. A is ask the question, are you going to kill yourself? B is validate. We want to listen to the veteran, validate their experience. And E is expedite help and encourage them to get help.
So what happens at the VA when you find out, or how do you find out that someone is thinking about suicide? So
we do have a community care notification system that's set up with all the hospitals in the catchment area. They will notify our VA community care team. We will then get that notification. That will come directly to myself and the rest of the suicide prevention coordinators. At that point in time, we will make it a point to reach out and make sure we are providing the services that that veteran is asking for and that that veteran needs. Within the VA, we have our own internal process as well. When a veteran is admitted for suicidal ideation, we're automatically notified, and there's a process in place to appropriately screen the veteran for suicide risk, and then do a complete comprehensive suicidal risk evaluation at that point, which determines from a clinical standpoint, we assess for both acute and chronic lethality risk, which is, in a layman's term, we are identifying what that suicide risk is for that person at that time. And then we will at that point in time identify whether we want to monitor that person more closely, or if we think just going through the standard care that we have available is appropriate for them.
So is there follow-up when you say you monitor, how long?
We will follow up, most certainly. So if we've identified a person to be at acute risk, the suicide prevention coordinators will most certainly reach out to that veteran, have that conversation with them. Not just us, but the other staff in the VA that are providing care for them will as well. We provide enhanced care when we've identified veterans at that point in time. And enhanced care means making sure they're attending their appointments, following up if they're not attending their appointments, reaching out, contacting them, sending letters. If need be, we will call the local authorities and do a safety check. We'll ask them to come out to verify that that person is safe. Also offering additional mental health appointments as well, so that they're getting all of the services that they need and that they're requesting.
Do you have any numbers on how many suicide encounters you may have each year? How many people are contemplating suicide?
At any given moment, we have around 100 veterans that we've identified to be at high risk for suicide. And
this is 100 a year? Or?
No, at any given moment.
Okay.
So like as we sit here today, I didn't look at the numbers before I came in this morning, but as we sit here today, I know we're somewhere in the 100 to 105 range of veterans that are receiving services at the Dayton VA that we've identified to be at high risk for suicide. That's pretty much a running total. It vacillates. I report on it monthly, but it doesn't vacillate a lot. It doesn't go up and down greatly.
You hear people say if someone really wants to kill themselves, there's really nothing you can do to stop it. So you're saying suicide is preventable, but haven't you heard that before as well?
I have. I would say there's nothing we can do to stop it if we're not asking that question, are you going to kill yourself? If we're not looking for those signs, if we're not validating what's going on with that person, that's really the big piece. Any of us that have worked in the clinical field in mental health know that, when a person is in that acute crisis at that point in time, all they really want from us is to be validated and to hear what's going on and then offer them hope and a solution. The solution is how do we increase those protective factors for them? Help them to identify, allow them to gain insight. It's critical.
Yes. And there is a new number that someone can call if they are in a crisis, the 988. I think it's been around for about a year now.
The 988 came out a little over a year ago, so it would have been in July of 2022. That is a national number for anyone to call that has any type of mental health challenges. When veterans call, if they want to reach the Veterans Crisis Line, which only deals with veterans, they can call 988 and press 1 at the prompt. Very simple. At that point in time, that'll get them over to our 24-hour Veterans Crisis Line, and a Veterans Crisis Line coordinator will answer the call. Now, one of the unique features to this is it doesn't just have to be the veteran. It can be, if you're concerned about a veteran, you can call. As long as you know that veteran's information, we would like to have that so that our team, so when that Veterans Crisis Line call comes in, the coordinator answers the call. If they're in acute crisis at that point in time, they will send emergency people out to that person's location if they provide the location. If the family member calls, they will try to reach that person while the family member is on. We will then get that information, what's called a referral or a consult, into our system that we have set up for that, and our suicide prevention team will respond within 24 hours to that veteran.
So having that 988 number, has that helped? I mean, because it's easier to remember. So have they seen an uptick in the number of people using that number?
Much easier. I am really starting to see an uptick at this point in time, paying attention to that. That's another metric that we track, and we are starting to see an uptick. It's probably right now about a 20% increase in the number of calls that we're starting to see. So we're getting the volume of calls that we're receiving monthly from the Veterans Crisis Line for our catchment area kind of coincides with the number of people we have on high risk that we've identified to be at high risk, but it's hovering around that 90 to 100 plus phone calls that we are responding to every month.
So if you could say something to a veteran who may be thinking about suicide, what would you say as far as, trying to give them hope?
Please call. We're here for them. We are best suited to help veterans, I believe. We are the largest healthcare system in the country, and what that gives us is an incredible amount of highly qualified, skilled individuals and the best tools and resources available to help that person. Quite simply, they do not have to go through this alone, and we are there for them.
That's important for them to know.
Yes, it is. Yes.
All right, Jay, thank you so much for being here and talking to us and giving us your expertise.
Thanks so much for having me.
And we are taking a break right now, and when we come back, we'll talk to two specialists out in the field doing their part to educate veterans on our suicide prevention program. Back in a moment.
I was a technical sergeant, E6.
I served in Vietnam in 1969.
I was a sergeant in the United States Army, paratrooper.
I am a U.S. Army veteran.
I was in the Marine Corps, 2000, 2004.
I served in the Army National Guard for almost 17 years.
I served in the United States Air Force for 4 years. This is my crew that I used to load bombs with.
I was a baby in this one. My first deployment in a Humvee and dirty and dusty.
This was related to my daughter, Brenna. It was her birthday. I was in Afghanistan, and I had my friend take this at the chow hall.
I truly almost don't recognize that person. It was the most meaningful period of my life.
It's just because it's hard being out. It's like still probably the best time of our lives, You can't get that anywhere else.
Have I ever asked for help myself?
It's always tough, right?
Yeah, that's a good question.
I can't say that I have.
I always feel like I can solve my own problems, but eventually, you just can't deal with it on your own.
I guess it's a part of the military too, right? Service before self.
It was drilled in, service before self.
There's something about the camaraderie of some of the people I know from Vietnam. There is something deeper, I think.
Most of us, we're not gonna admit that we need to help.
If you don't have someone to kind of help you guide those thoughts, it can be really bad.
And you start to question, maybe people would be better off without me, When you realize that you're not alone, once you take that first step, there's so much support.
We just have to take the action to go and get it.
We are back talking about Suicide Prevention Awareness Month. And joining me now is Josh Nordstrom, Senior Social Worker, Suicide Prevention Coordinator, and Matt McLaughlin, Community Engagement Partnership Coordinator with the Suicide Prevention Team. Thank you both for being here.
Thank you for having us.
All right, Josh, we'll start with you. Tell me, what do you do in your job?
So as a Suicide Prevention Coordinator, I work as a part of a team, and we assess veterans who are alerted to us who might be in need for any additional care. So if somebody's having a real bad period of events and there's some concerns that they might be suicidal, we're going to reach out to that veteran, find out some information, and see what we can offer to help, link them to other resources. We have a couple of different ways that we're notified. One's through the Veteran Crisis Line, the 988 number that you talked to Jay about earlier, as well as community care notifications. So any veteran that checks into a hospital in our 17-county catchment area that has any suicidal ideations or suicidal behaviors or a mental health disorder that might be akin or might lead to suicidal behaviors or suicidal ideations, we're alerted so that we can talk to that veteran, find out what's going on, see if we can get them linked up to care within the VA system.
And how soon do you reach out to that veteran after you are alerted?
Sometimes the same day, but definitely the next day. So it depends on when we're notified. If we're notified early enough in the morning and we're able to put it into the rotation, we will reach out to them that day. If it comes in the afternoon, we'll address it the next business day. But there are many times where there could be a veteran on campus who's working with another provider in a different clinic, and that provider is feels uncomfortable, that it's outside of their wheelhouse or it's outside of their depth, and they're like, we need help. They'll reach out to the team, and then we will offer that individual provider resources, or we will take a warm handoff and talk to that veteran ourselves.
All right, and Matt, what about you? What's your job?
My job is Community Engagement and Partnership Coordinator. It's a fairly new position in the VA. It started here in Dayton about 2 years ago. And our job is essentially to work with the community and make the community better at caring for veterans and taking care of service members, veterans, and their family. So we take a community-based approach to suicide prevention versus a more clinical, individual approach that the case management side of the house and the suicide prevention coordinators take. So what that really looks like is me educating the community on the risk factors and gaps and barriers that exist for service members, veterans, and their family, and working with different community stakeholders to identify solutions within the community that we could implement to eliminate those barriers and gaps.
So on a daily basis, how do you help a veteran who's struggling?
My day-to-day mostly works meetings, emails with community stakeholders. We work with a lot of suicide prevention coalitions to develop action plans. So it's a more long-term approach, more of a public health approach. So it doesn't have, the immediacy of the clinical work that our suicide prevention coordinators take, but it's supposed to have that more long-term, more stable kind of community is better at catching and caring for those veterans. Most of our veterans are not enrolled in the VA, so we don't have our hands on them. Most of the veterans that die by suicide, about 60%, have not had a VA appointment in more than 2 years. So most of those veterans dying by suicide are out there in the community. And if the community's not aware of that and not identifying our service members, veterans, and their family, and figuring out how they can serve the service members, veterans, and the family, we're not going to have a meaningful impact on reducing veteran suicide deaths. It needs to be a community effort, one, from the very functional reason that most of the veterans are not enrolled in the VA. We can't help the veterans we don't have our hands on. And really the strongest protective factors against suicide are a sense of belonging, a sense of purpose. And the VA really can't give that to anybody. A mental health provider really can't give that to somebody. Family, friends, and community can. So if we identify where those gaps are and why a veteran's not feeling that in the community, and we can implement some action plans that address that, we can have a meaningful impact on veteran suicide prevention.
So it's important really for family members to be more involved as well in understanding what their loved one is going through. Because you hear after the fact, people will say, oh, I never knew that this person was suicidal or whatever until after the fact. But there has to be maybe some ways that families can start noticing things, sooner.
So that's actually the most common thing that a survivor of suicide says. And when we say survivors of suicide, that's the family, friends, and loved ones that live on after someone's suicide death, is they had no idea it's that bad. Many people don't disclose their mental health issues, or they're struggling with suicidal thoughts, and they're thinking about killing themselves. Veterans are notoriously keep it close to the chest and don't disclose that for a lot of reasons. That's one of the stigmas out there that I work to address in my education stuff. If you suspect that, there's a belief if I ask somebody, are you thinking of killing yourself, that I'll somehow implant that idea in their head, and that's absolutely not true. If they're thinking about it, they're already thinking about it. And asking that question actually shows that you're a safe person to talk that about. You're not uncomfortable, but you're willing to have I tell people, it's not about feeling comfortable talking about suicide. Most people don't. It's about feeling competent and I'm able to talk to somebody about suicide. Because it is a very uncomfortable conversation. If you're comfortable talking about it, then I don't know anybody that is.
Right. But if you can talk to somebody about it and it ends up making them not want to do it and changing their mind, it's worth it.
Yeah.
Josh, can you give me an example of when you maybe helped someone who was thinking about suicide and maybe help them to think otherwise?
Absolutely. So with all of our incoming sources through the Veteran Crisis Line and through community care networks, and then veterans coming into the hospital themselves, we get to talk to a lot of different veterans as a team and find out what's going on. And when we do talk to a veteran who's expressing some concern and some unhealthy thoughts, negative thoughts about themselves or their situation, we do have the opportunity to find out from them firsthand what's going on, what are those thoughts, what are their perceived barriers to getting care. And to follow up with the question that you had with Matt, we do have the opportunity in this realm to try to bring in their families or their close friends or their primary battle buddy, if you will, to develop a safety plan with them. So that this way, them and their partner or their best friend is a part of that journey of figuring out what are the triggers that cause me to have negative thoughts. When I have these negative thoughts, what are some things that I can do by myself? What are some things that we can do together? And we walk them through this safety plan. So it's kind of like if this, then that. And it's all in their words, and we're able to create it and send it to their home. And we encourage them to give copies to the people that are close to them in their life, so that, like what Matt was talking about, is part of the military culture is shut your mouth. So if their friends are able to watch with their eyeballs and they can see what's going on, be like, oh, you're doing that thing that I'm worried about. What about if we go to wherever together? What if we go and do this? So just within this week, I think I created 3 safety plans with 3 different people, and they've all been mailed out. And they're either out the door that day or they're out the door the next day. And we have the ability to send a lot of free information and resources. So we mentioned gun locks. We were talking about gun locks earlier. We give out gun locks to anybody who wants it, because it does a lot more than just protect the firearm. So some people, death by firearms is the most common in the state and within the country for our veterans, but it's not the only one. We have accidental overdoses, and the cable gun locks that we give out work great for liquor cabinets and medicine cabinets or any kind of cabinets that has pulls. They get to keep the lock, they get to secure it, and it doesn't have to be forever. It just has to be used during the period of time when they are feeling unwell or they're not trusting their long-term decisions. And they're going to hopefully place items inside of a cabinet or lock up the firearm and just create an extra barrier between them and a long-term choice. So if they want that lock, they just ask you for it? Absolutely. And we, inside the mental health clinic at the Dayton VA, there are gun locks on the counters, and we give out gun locks to different clinics in large quantities. So if any veteran coming in for any of the intake process is expressed any negative thoughts, all of the providers that are doing intakes or have firearm or have gun locks on their in their office and have the ability to offer it then and there, they can come and get it at the Dayton VA any day of the week that we're open. As coordinators, our role is not to become their therapist. Our role is to help remove any barriers that they have at getting help and link them to the most appropriate clinic so that then they can begin getting the care that they need there.
But they have to do the work.
They have to do the work, but we can cheerlead them and we can help open doors and we can help remove barriers. And a lot of that comes from just that sitting down, having a good customer service conversation, treating everybody like a human and not like in the next case or whatnot, and saying, like, how can I help you today?
Are there any myths out there that you guys would like to dispel?
Like, a lot of my job focuses on like the myths that like caregivers or first responders could address, and we already kind of discussed the you're not going to incept or implant the idea that to kill yourself. If you ask somebody, are you thinking about killing yourself? Another one is that only a mental health provider can truly help somebody that's in a suicidal crisis. All the studies that kind of come back from people studying people that have thought about attempting suicide and then made that other decision and went the other way, the most helpful thing to that moment was a validating, empathetic, caring response from a loved one or a trusted individual. It's not a mental health professional. So it's often the people that are not mental health professionals that save somebody that's contemplating making a suicide attempt. And then we've gone from like changing the language from commit suicide to talking about someone dying by suicide. Like the term commit suicide comes from when suicide was a crime in this country. It's no longer a crime in this country. Suicide is a means in which somebody dies. It's a result of a mental health crisis. So that's one of the things we're trying to work with our education efforts, is to eliminate some of that stigma or this idea that like they have control over this.
And Josh?
First myth I would like to try to dispel is that people are talking about suicide. They're just making it up. They're just doing it for attention. That one has been disproven as well. Many times people will talk to a stranger about wanting to die by suicide, or make an offhanded joke if they get new pills at the pharmacy, like, I wonder how many of these will take to kill me. Sometimes people are trying that shoe on, if you will. If somebody's making a comment about suicide, even if they're joking about it, it's worth asking, are you thinking about killing yourself? And we do
Because it could be a cry for help.
It could be a cry for help, and it could just be one of those quiet little things that they said just to blow off just enough steam to go back home and keep their mask on. And we do want to ask the question of, like, are you thinking about killing yourself? It's a straight, direct, hardball question, and many times, like Matt said, if you ask the question, the person believes that you're invested in it, that's a good thing. The other myth I would like to dispel is about the Veteran Crisis Line, the 988 number. Many people believe that if I call this number, the Sheriff's Department's going to come kicking down my door. And that is an untruth through numbers and through practice. So there's been about 8 million calls and texts and chats and messaging services into the Veterans Crisis Line since its inception. And only about 1 in 32 result in first responders coming to the home. That's police and fire and paramedics combined. So they will come to the house only if they need to.
So is there anything that you would want to say, I'll start with you, Matt, to veterans who are watching this, if they're even thinking about suicide?
Like, help is there. A lot of times people kind of isolate themselves. Veterans have a habit of isolating themselves and think, I'm the only one that feels this way. I want them to know they're not the only one that feels this way. And you can get help, and it can get better, and that there is hope. So just ask for help, whether it's calling the crisis line, talking to somebody you trust. Just don't keep it a secret.
I would like to say to any veteran that is out there watching this right now, you are not alone. You never did anything in the military alone. You always had a fire team or a buddy team or some other group of people. You might feel alone right now. Give us a call. We're here to help you. We want to get you to the best place. You are never alone. Please give us a call.
Thank you very much, both of you, for being here. We appreciate your expertise as well. And I think you said some very important things, and hopefully what you said will resonate with people. So thank you very much for that. And again, the slogan for this year is don't wait, reach out. And we encourage any veteran thinking about ending their life to please reach out for help. It is available. That is another edition of Veterans Health Today. Veterans, if you want information about enrolling at the Dayton VA, you're encouraged to call the Medical Center at 937-268-6511, extension 2035. Or you can call one of our 5 community-based outpatient clinics, or CBOCs, and you see the numbers there on your screen. Thank you so much for watching this program. Veterans, thank you for serving a grateful nation. We'll see you next time.